Dr. Naeem Khan Durani.
Thank you, Dr. Univa, for your kind and gentle introduction. I have to put my mask off because the mask is for the protection, but it also masks the voice, so you will not be hearing me very clearly. So now you know that how to control the diabetes and how to control the how why to treat. My question is that why we treat the diabetes? Why we are saying that these numbers keep the fasting glucose level below 120, keep the random blood glucose level below 180, and keep the HbA1c individualized based on the patient criteria, that is 7 or 6.5 or 7.5 in some patients. So why we are trying to achieve these numbers are for two complications which are very much common in the diabetes. The diabetes, the chronic complication of the diabetes is diabetic foot, which is, I think, always underlooked at the clinic level, because I've seen the patient, the consultants, the general practitioners who usually treat the diabetes based on the numbers to control the diabetes. They do not look for the complications, and this is one of the complications which can increase the morbidity of the patients and the quality of the life of the patients if this complication of the diabetes occurs in the patients. So I will be discussing the introduction of the diabetic foot evaluation, the risk factors, approach, the comprehensive foot exam, and people will look at some additional evaluation, and the most important is how to prevent it from lasting. So the foot problems are an important cause of type 1 and type 2 diabetes, and it occurs in 34% of both the type 1 and type 2 diabetic patients. And the management of foot cancer, we know that it takes a lot of cost and admissions, and if the long admission stays in these patients when the patients develop the diabetic foot ulcer, and they have 2.5-fold increased mortality as compared to the diabetic patients who do not have foot ulcers. So, potentially preventable, the first event, a minor trauma which can be discovered in these patients, and systemic screening examination like the neurological exams and the vascular exams can be carried out in our clinics to look for the risk of the diabetic foot. So the risk factors most common are the previous foot ulcerations, neuropathy, that is the loss of the protective sensation which nature has provided us to protect our legs, and we know that due to the diabetic neuropathy, this protective sense is lost, and the diabetic patients are not aware when they put on the very hot and cold places. They can burn their foot easily. The foot deformity which occurs in the patients can prone them to the ulcer formation and the diabetic foot, and ultimately the amputation. The vascular diseases can be the risk factor in these patients, and it can lead to foot ulceration due to the ischemia. So one study it was a community-based studies performed in 1,294 patients of type 2 patients. The incidence of lower extremity amputation was 3.8 per 1,000 diabetic patients per year. And predicted for the amputation were foot ulcers with a significant hazard ratio, the neuropathy, and the ankle brachial index of less than 0.9 patients had a very significant risk factor for the diabetic foot. So when we see the diabetic foot, 80% of the times these are caused by the neuropathies. And due to the neuropathy, there may be some vascular. We know that the nerve not only controls the sensation, but it also controls the flow of the blood to our foot. So this can be interchangeable. What happens when the neuropathy occurs? There is a decreased sensation of pain and perception of pressure. The patient will be standing for a long time and he will not feel pain. Ultimately, it can lead to ulceration. The anatomic deformity like such as the hammer toes, which are very common, the claw toes and the charcotopathy, which can occur, and these can lead to the ulcer formation. And we know that the ulcer formation, once that it occurs, it is very difficult to heal these ulcer in diabetic. Let's see how to treat these ulcers. In one study, the SGLT2 inhibitor, the canagliflozin, compared with the other oral glycemic agents, were associated with increased risk of amputation. And these were in patients with a history of amputation or peripheral vascular disease. But the other studies and the meta-analysis didn't find any significant risk of this amputation with the SGLT2 inhibitor. But we must be cautious in patients until we have further studies which will be occurring in the future. So we should be using these agents in the high-risk patients and the patient with history of amputation. So the classification of the risk in the on the comprehensive foot exam is we have grade the risk categories into 0. That is, there is no loss of protective sensation, and there is no peripheral artery diseases and no deformity. So the recommendation for them is to wear the appropriate or footwear. Why appropriate? Because we are seeing in our patients, the patients are coming in our patients, they are wearing the shoes which place their foot to the risk of trauma, very well hygiene of the patient, which can lead to complications of the diabetic foot. And the grade 1 is the loss of the protective sensation plus minus. These patients, we should advise them to wear the accommodative customized for the patient. And if there is any deformity which can be corrected, cannot be managed by the appropriate footwear, they can be corrected by the appropriate surgery. And the grade 2 is for is the presence of the peripheral artery disease plus minus loss of protective sensation. For these, there are the similar recommendation of category 1, and the 3 is the history of ulcers or amputation. For these are the similar recommendation of the category 1. And whenever we found some peripheral arterial disease, we must refer them to the vascular surgeon. They can open their circulation. It can prevent the ulcer formation and will help in the healing of the ulcer as well. What you ask for the patient, the duration of the diabetes is very important. As we know that the chronic complications usually occurs years after the diagnosis of the diabetes. But we must also emphasize that a lot of patients, type 2 diabetic patients, when they are diagnosed, we do not know that when they develop the diabetes first. Many of the type 2 diabetic patients can present with the complications of the diabetes, like the macrovascular complications. You might find some patients who are admitted in the stroke ward or the cardiac ward, presented with the MI or the stroke, and when their blood glucose levels were checked, they were diagnosed diabetes at that time. So the control of the diabetes is very important, not because for these numbers, to keep these numbers at the target level, but to prevent the complications. History of prior foot injury is very important thing in deformity or prior ulcers. Lower limb bypass or amputation history is very important. Presence of claudication, that is the feeling of pain after walking a few distance, and these pains are relieved by treating the rest. Can address a factor for the diabetic foot. And last but not least, of course, the smoking. And if the patient is smoking, you must advise them to quit this smoking. The patient should be questioned about what are the type of the sensation. They are either they are burning, numbing, tingling, or fatigue, cramping, or aching. What is the location of the symptoms, that is it is occurring in the cough or in the fit or elsewhere. Have these symptoms ever you awoke at the night, and the symptoms, the timing of the symptoms worse at night, present day and night, present only during the day. How our symptoms are relieved, walking around, standing, sitting, they can give you some clue about the pathophysiology of the pathology of the diabetic foot ulcer. The key component of diabetic foot exam is the inspection, which we will discuss later. The muscular deformity, that is the hammer toe, the claw toes, and the Charcot joints. And the neurological assessment is very important in these patients by 10-gram monofilaments, plus minus any one of the following, that is the vibration using 128 hertz tuning fork, the pinprick sensation, the ankle reflexes, and the vibration perception threshold. The vascular assessment is very important. Of course, we must palpate their pulses at the dorsalis pedis and the popliteal and the femoral. So the inspection, assessment of pedal pulses, assessment for loss of protective sensation. Inspection is very important. We must look for any gross deformity of the foot, and we must look under the web for the presence of any infection, and we can find some lesions which can suggest why these lesions are caused. Like if there are some, the patient is wearing some tight, they might be having some pressure points ulcers on their lateral or medial aspect of the foot. And the macerated foot, which is called the acute foot, occurs due to the expiration of the web spaces, and they are often painless and can lead to infection, superimposed infection in these. The callus formation areas are other areas where they can be infected. We can look for them. The presence of erythema, swelling, which can be sign of tissue damage, that is the inflammation or infection. Bony deformities should be checked. The joint mobility should be checked whether how they have bony deformity and how they are. This is a picture of foot ulcer in the dorsum of the metatarsal head, and it is the full thickness to diabetic wound. And if you note the fingers, it has been round, and if the dorsal pad has been shifted dorsally, you can appreciate the ulcer formation at the tip of the fingers as well. This is the Charcot joint. When this abnormality is picked early, you can avoid the complications of the deformity of the foot. Initially, it presents like redness, warmth, and at this stage, if you can pick this Charcot joint and advise for the protective wearing, avoiding to put the pressure on that foot, you can avoid this deformity. Like in this case, you can see the arch of the foot is lost, and there is a ulcer which can put the patient the formation amputation. Assessment of the pedal pulse is very important. I discussed that for the pulses taking from the foot going upwards. You can find the pulse at the dorsum of the foot. You don't need to look for the proximal pulses as the circulation is coming to that. So whenever where the circulation is impact, then you should proceed proximally. Whenever there is peripheral arterial disease on inspection, you can find the shiny skin, the loss of the hair, and you can see the bluish discoloration, like the gangrene formation. Patient with clinical evidence of peripheral arterial disease, the endotracheal index should be performed, which we will discuss later to guide further management. The presence of peripheral arterial diseases is also usually associated with, as it is atherosclerotic diseases. The patient might have been having atherosclerosis in the heart, in the brain, so they are also at the risk of development of the stroke, and cardiovascular disease can occur in these patients. So it is not a disease related to the. So how to assess for the protective sensation? We can check by the tuning fork, that is the 120 hertz tuning fork. We usually in our country we have the plain tuning fork, but in some part of the like in the world and the AQ where I practice, we have a graded tuning fork which has a number from 0 to 8. It can tell how much vibration has been impaired in these patients, because when the tuning forks start vibrating, you can see some numbers, and after decreasing the frequency of the vibration, more numbers occur, and when you should ask the patient when the vibration stopped, and you can look at the tuning fork. It will guide you how much is tuning fork reading. Usually at AQUH, it is 0 to 8, and from 6 it is usually neuropathy. We diagnose them as a neuropathy. The monofilament testing can be done by many ways. Some use 10 points in each leg, some uses 6 points, and in this the diagram, there is a 12 points, including the both. You can check in these areas the sense of the touch of the monofilament. So this is a monofilament. It should be used properly, and it should be at the 90-degree, and you should bend properly, and ask the patient whether he can feel the pressure of that monofilament or not. So this is a neurostesiometer, which can electrically measure the sense of the vibration, which is called as the vibration pressure threshold, perception threshold. Usually it is more than 25. If it is less than 25, it has 83% sensitivity for the diagnosis of peripheral neuropathy. But you must also keep it in mind that this vibration pressure threshold changes with the age. So the different age has a different vibration pressure threshold. The additional evaluation includes the evaluation of the foot ulcer, which is present, how to evaluate that ulcer, evaluation of the peripheral arterial diseases, evaluation of the neuropathy. So evaluation of the existing foot ulcers include, you must grade them and look which grade is that. Like the grade 0 has a pre or post operative lesions which is completely epithelialized. It can be staged, which we will discuss later. And the grade 1 is the superficial wound. It doesn't involve any capsule or muscles. And in grade 3, the wound penetrating to the tendon or capsule. And in grade 4, there is involvement of the bone, that is the osteomyelitis. But in the staging, we'll see whether A, there is no infection, no ischemia. In stage, in B, there is infection. In stage C, there is ischemia. And in stage D, there is both ischemia and infection. So this is the grade 1 with the complete epithelialization of the wound. It could be stage A and A to D, the presence of the ischemia infection. thickness wound, which is a similar picture we had in our previous slide. It is a deep wound, but it is not penetrating to the capsule and muscles. Grade 3, that is, it is now going to the capsule. Different artery disease or peripheral neuropathy, because these patients who take the pedogram of these patients, height for the pressure areas. My counter is not working. If you can see the pedogram on the left side, it has some red areas which are showing that these areas are there is a lot of pressure on these areas, and based on these pedograms, you can advise for the accommodative to relieve pressure areas on these two. Evaluation of the neuropathy. If there is any neuropathy, you must also look for other causes of the neuropathy, like only diabetes is not the cause of the neuropathy. You should look for the TSH and B12 level in these patients to rule out other causes of disease causing neuropathy. The preventive foot care is very important. Avoid smoking, avoid going barefoot, and especially on the hot decks and hot sands. Last night I was in the Faisal Mosque, and I was walking on barefoot, and it was a very hot weather in the Islamabad, so my feet were burning. I felt that it's me that I'm feeling that burning on the floor, but the diabetic patient who walk on these areas will be very difficult to walk on these areas. And as my sensations detect, whenever I felt heat inside my foot, I put out my feet from that area and keep walking. So my legs were protected. But the diabetic patients walk on these areas, which is very difficult to protect their self. This test water temperature before going to bath, or if you are making our area also, you should check the temperature of the water by your colleague, or if it's not available, you can check the temperature of the white water by your this elbows. The uh, the trimming of the nails is very important. They should keep cutting the straight, avoid cutting the cuticles from which areas the infection can spread to the diabetic patients who are very vulnerable to the infection. Wash in a lukewarm water daily through, and they should dry after washing their hands, legs. Shoes should be snug but not very tight, and it should be customized. If there is any deformities or any ulcer present, socks should be wet and uh, made of cotton, not nylon, and should be changed daily to avoid the complications of the diabetes. Here I'm ending my presentation. Thank you very much. If you have any questions, you're welcome.